Good afternoon. We're going to commence the Health Committee meeting of the Assembly for April 28th. A couple of quick announcements and we'll do the first order of business. First, time limits. We will hear two witnesses per side with a time limit of 3 minutes each. Two witnesses per side with a time limit of 3 minutes each. Additional witnesses after that, please state only your name and organization for the record and your position on the measure. We're going to have a long meeting today, so I want to ask that everybody comply with the committee's rules. Our consent calendar. The following bills are proposed for consent. Item 12, AB 847, Assemblymember Mullen with amendments. Item number 15, AB 861, Assemblymember Mainshine with amendments. Item number 18, Bill 990, Assemblymember Bonilla. Item number 21, AB 1211, Assemblymember Mainshine. Item number 25, AB 1299, Assemblymember Ridley Thomas. Item number 28, AB 1423, Assemblymember Stone. That's our consent calendar. We also have a special order of business today at 2 o'clock for item number 23, AB 1254, Assemblymember Grove. For amendments only, AB 1357, Assemblymember Bloom is noticed in the daily file. For adoption of amendments only, we will adopt the amendments, including an urgency clause, and refer back to Health Committee, and the bill will be set for next week. So the substantive hearing will be next week. Today is for amendments only. Removed from today's calendar is item number 29, AB 1434, Assemblymember McCarty. With that, I see Assemblymember Chow here. We're ready to start with our first item of business. Item number 1, AB 41, Assemblymember Chow.
Thank you very much, Mr. Chairman and members. I'd like to start off with AB 41. AB 41 will prohibit a healthcare service plan contract or health insurance policy from discriminating against any healthcare provider who is acting within the scope of that provider's license. Federal healthcare reform has resulted in millions of people in California signing up for the healthcare insurance through our insurance exchange. This influx of newly insured will stress our already overburdened healthcare system that is facing severe shortages of healthcare practitioners. We need to ensure that we utilize all of our healthcare practitioners whose scope of practice and whose education and training would allow them to perform more vital functions. Section 2706 of the ACA bans discrimination against whole classes of healthcare providers. Unfortunately, health plans and insurance companies commonly limit the types of healthcare providers are allowed to provide or deny reimbursement for services that the plan covers. For example, optometrists who are permitted to provide routine vision care under a health plan or insurance contract are often prohibited from treating medical eye conditions such as glaucoma that are within their scope of practice. Another example, chiropractors can perform medical evaluations under their scope of practice, and insurance companies cover that service. Yet, the insurance company will not pay for it merely because the service was provided by a chiropractor. There are a lot of different healthcare providers that are seeing denials of reimbursement from healthcare insurers, including the naturopathic doctors, nurses, midwives, and dental hygienists, for example. Provider discrimination is not only wrong in practice and principle, but it is also anti-competitive in nature. It limits or even denies patient choice and access to a range of beneficial providers and results in less than ideal and optimal healthcare delivery system. AB 41 prohibits a healthcare provider or service plan or contract or insurance company policy issued on or after January 1st, 2014 from discriminating against any healthcare provider who is acting within the scope of that provider's license. Today, I have a sponsor from the California Chiropractic Association here to testify in support of the bill.
Mr. Chair and members, Monica Miller on behalf of the California Chiropractic Association in support. I want to remind the committee that this is a bill you saw last year, AB 2015. It came out of this committee 18-1 with bipartisan support. I have with me today Dr. Ken Weiner from the California Chiropractic Association to testify to the substance of the measure, and we are available for technical questions as well. Thank you.
Good afternoon. My name is Dr. Kenneth Weiner, and I'm the Legislative Chair for the California Chiropractic Association, and I'm here today in support of AB 41 by Assemblymember Chow. Specifically, AB 41 is needed because both the Department of Managed Health Care and the Department of Insurance have stated that while Section 2706 of the Federal Affordable Care Act, they do not have a state statute in order to enforce that section. AB 41 would do the following. It would expressly codify Section 2706 of the federal law that prohibits health plans from discriminating against any professional category of healthcare provider when making decisions about what type of providers to include in networks or which services to cover. Also, the current state law provides for regulation of healthcare service plans and health insurers by the Department of Managed Healthcare and the Department of Insurance. This bill would clarify that these departments have the statutory authority to enforce a ban on provider discrimination, just as they have the authority to take enforcement action against any other discriminatory acts by healthcare service plans and insurers. Specifically, AB 41 would prohibit a healthcare service plan contract or health insurance policy issued on or after January 1st of 2016 from discriminating against any healthcare provider who is acting within the scope of that provider's license, that has a contractual relationship with the healthcare plan and performs a service that's a covered service by another provider who is also on the exchange. It's important to note that AB 41 is not in any willing provider bill. It does not require health plans to contract with any individual provider who is willing to abide by the terms and conditions for participation established by the plan or the insurer, but rather prohibits exclusion of an entire class of provider for discriminatory reasons. AB 41 also does not prevent a healthcare service plan or insurer from negotiating reimbursement rates based on quality performance or performance measures. These are negotiated between the plan and the provider they choose to contract with. I urge an aye vote on AB 41. Thank you.
Thank you. Additional witnesses in support?
My name is Dr. Greta D'Amico, a naturopathic doctor from Auburn, California, representing the California Naturopathic Doctors Association, urging an aye vote on this.
Thank you. Additional witnesses in support?
Okay. Megan Maddox with the California Pharmacists Association in support.
Connie Lynn, student pharmacist in support.
Sean South on behalf of the California Primary Care Association in support.
Stephen Samuels, student pharmacist at the University of California, San Francisco in support.
Christine Bulo, student pharmacist in support.
Jane Liu, practicing pharmacist in support.
Mohsen Khan, student pharmacist in support.
Rebecca Lima, student pharmacist in support.
Tatev Kirikosian from California Northern University in support.
James Erbestando, student pharmacist, University of the Pacific in support.
Janet Yuen, student pharmacist from University of the Pacific to support.
Jackie Chow, student pharmacist from University of the Pacific in support.
Jennifer Tannehill with Aaron Reed and Associates on behalf of the California Dental Hygienists Association in support.
Donna Fitzgerald, CSHP in support.
Keith Soul, pharmacist in support, California's Society Health System pharmacist.
Thank you. Any witnesses in opposition? Seeing none, any questions or comments from members of the committee?
Move the bill.
Second. We don't have a quorum yet. So we're starting this hearing as a subcommittee. When we have a quorum, we can receive motions and seconds. Unfortunately, we can't do that yet. Mr. Chow, would you like to close?
I respectfully ask for your aye vote. Thank you.
Thank you. We'll take this up for a vote at the appropriate time after we've established a quorum. Thank you very much, Mr. Chow. You have a second bill?
That's correct, Mr. Chairman.
Item number 10, AB 502. Please proceed when you're ready, Mr. Chow.
Thank you again, Mr. Chairman and members. I'm here to also present AB 502, which will improve access to dental hygiene care in underserved areas of the state. I want to start off by accepting the amendments listed on page 5 of the analysis to clarify that 40% of the patients served by the registered dental hygienist in alternative practice, or APs in short, must be from underserved populations in order to continue working in a dental health professional shortage area, or DIPSA for short, if it loses that designation. APs are licensed registered dental hygienists with specialized training that allow them to practice in settings outside of the traditional dental office, such as schools, skilled and residential care facilities, hospitals, and private homes. However, a number of situations will result in the reduction of access to these APs. California law allows APs to practice in DIPSA areas. However, once the area is no longer designated as a DIPSA, they must close their practice. Second, while some dental insurance companies recognize APs, many insurance companies often deny AP reimbursement for covered services. And finally, the Business and Profession Code authorizing APs to establish corporation, but the corporation code does not have language to do so, leaving them without critical protections. AB 502 would address these issues and ensure that the public has access to quality dental hygiene services by, number one, allowing APs to continue to practice in a DIPSA area so long as they continue to serve the underserved populations. Two, requiring insurance companies to reimburse contracted APs for dental hygiene services covered by the insurance. And finally, clarifying that APs are authorized to establish corporations under the Corporations Code. I have my witnesses here from the Dental Hygienists Association to support the bill.
Good afternoon, Jennifer Tannehill with Aaron Reed & Associates on behalf of the California Dental Hygienists Association. We want to thank the author and the committee for working with us on AB 502, and we accept the committee's amendments to look forward to continue to work with the stakeholders on this bill. We have taken substantial amendments to address concerns while maintaining the goal of the bill to remove some barriers to dental hygiene care for underserved populations. Today I have with me Corrine Strickland, a practicing registered dental hygienist in alternative practice and president of the California Dental Hygienists Association, with me here to testify.
Good afternoon, Chairman and members. My name is Corrine Strickland. I am president of the California Dental Hygienists Association. RDHAPs are registered dental hygienists in alternative practice. Alternative practice hygienists are those who have practiced for 2,000 hours and have gone back to school to receive 150 additional hours of education and training specialized to serve elderly and disabled populations. APs provide dental hygiene care independently and outside of the traditional dental office in order to reach these underserved populations. Many Californians have difficulty accessing care through a traditional dental office setting, or there are many times a lack of dentists in their communities. Alternative practice hygienists take dental hygiene care to the patient. APs serve the elderly and poor, work in skilled nursing facilities, homes of the disabled or elderly homebound, in schools, or in dental health professional shortage areas. RDHAPs can have offices or utilize mobile units to deliver this care. APs are recognized dental providers and have their own national provider identification number. Denti-Cal also recognizes RDHAPs as billable providers. AB 502 improves access to dental hygiene care by allowing APs who establish practices within designated dental shortage areas to continue to provide care to their patients when the shortage area designation is removed. It also requires insurance companies to reimburse APs for dental hygiene services legally provided within their scope of practice and already covered by the insurance policy. Clarifies that alternative practice hygienists are authorized to establish corporations. APs have practiced in California for over 15 years and have come up. We need to update our statute to address roadblocks to care that have come up over these evolving years. I respectfully ask for your aye vote.
Thank you. Additional witnesses in support? Any witnesses in opposition? Please come forward.
Good afternoon, Chair and members. Brianna Pittman with the California Dental Association. Unfortunately, we are here in opposition today. Of continued concern for CDA is the proposal to allow an RDHAP to continue their solo practice in a DIPSA after it loses its designation. So far, CDA has not seen any evidence of an existing or an imminent problem where this has happened and put either a community's access or an RDHAP's practice at risk. We continue to like to see answers to the policy questions that are listed in our letter and believe that the RDHAP practice was created to fulfill a need for underserved populations, not to create RDH independent practice. So if the bill moves out of committee, we look forward to continuing to answer these questions and work on the issue, but at this point we are opposed and ask for a no vote. Thank you.
Thank you. Additional witnesses in opposition? Seeing none, any questions or comments from members? Dr. Wood.
Yes, I just want to comment on a couple of items. First of all, I too haven't really ever seen an issue where a hygienist in alternative practice has been forced out of practice in a DIPSA area. So it feels a little bit to me like a solution in search of a problem at this point. There haven't been any that I'm aware of, and our conversations that couldn't be demonstrated. So I was hoping that you would be working with the opponents to come up with language that would be more suitable, and I'm not sensing that that's really happened. So I'm a little concerned about that. And if the original intent of the RDHAP was to serve in underserved areas, I'm a little puzzled as to why you would want to then limit it to 40%. I would think that number personally should be higher. If that was the true mission of the RDHAP program, why would you limit it to 40%? So those are my concerns. I am prepared to vote for the bill to move it forward so that these conversations can continue. But those are two things that certainly the first one is something I raised during BNP, and I'm not sensing an answer. Trust me, if a hygienist was threatened in some way that they might lose their practice in a DIPSA area, I would go to bat for them, especially because as I know there are some that are practicing in my area. So I'm just concerned that it's a solution in search of a problem.
Ms. Stanhill, would you like to?
If I might, just for a moment, we have a quorum now, so I want to establish it. Madam Secretary, please call the roll.
Bonta?
Aye. Here.
Mainshine? Here. Bonilla? Burke? Chavez? Chu? Gomez? Gonzalez? Hernandez? Lackey?
Here.
Nazarian? Patterson? Ridley Thomas? Rodriguez? Santiago? Steinnorth? Thurmond? Waldron? Wood?
We have a quorum. With my apologies for the interruption, Assemblymember Chow.
Absolutely. I'd like to defer that question to Ms. Tannehill.
Thank you for your comments, Assemblyman Wood. We've appreciated the dialogue that we've had with your office and your openness and willingness to work with us and talk with us about these issues. The dental health professional shortage areas are a federal designation that are overseen by OSHPD and are reviewed every 4 years to maintain that designation. So if an area, specifically what was an issue for us and why this bill was brought forward to us, was that there were APs in the San Luis Obispo area that were their DIPSAs up for review, and they were looking at taking away the designation, and the APs helping gather information as to why there really weren't still enough providers in the area, and that removing the designation would be a problem. And then that's when the reality came forward to us that actually in the BMP code, in our statute, there isn't a provision for them to continue to see the patients that they were seeing when it was a DIPSA. So the feds can come in and say that this area is a dental health professional shortage area, and by doing so they're trying to draw more providers to that area. So it doesn't make sense that when you're drawing providers to the area and they've started to meet that need, that if the designation is lifted and that they're doing a good job meeting the need of those patients, that you would then take those providers out of the area and tell them that no, you can't continue to serve all those patients that you were serving before. And to your second point, the mix of the 40%, we came up with that number in an attempt to address some of CDA's concerns that they wanted to ensure that those underserved populations would still be served. And you as a provider know that with the very low reimbursement rates for Denti-Cal, you can't have 100% of your practice being, underserved people. Otherwise, you're paying actually to provide that care because the reimbursement rates are so low. And in discussions with APs, we thought what would be a good mix, and the 40% number is where we got that one.
Assemblymember Lackey.
Yeah, just real quickly, I wanted to ask the question, are there any DIPSs currently in the threat of losing their designation up for review next year?
Yeah, I think that was addressed briefly. As of today, we have not received any revocation per se. However, in the St. Louis Obispo area, we have had practitioners who received notification from the federal government saying that the designation is going to be lost. So there is a threat that may happen. Now, I must admit also that this is also a proactive measure. I think in the event that happens, then we have some measure to counter that. Thank you.
Additional comments or questions from members? Seeing none, we can entertain a motion. We have a motion. Any second? We have a motion and a second. Assemblymember Chow, would you like to close?
I respectfully ask for your aye vote. Thank you very much.
Thank you, Assemblymember Chow. Madam Secretary, please call the roll. The motion is due pass as amended to appropriations.
Bonta?
Aye.
Bonta, aye. Mainshine?
No.
Mainshine, no. Bonilla? Aye. Bonilla, aye. Burke? Aye. Burke, aye. Chavez?
No.
Chavez, no. Chu? Gomez? Gonzalez? Hernandez? Lackey?
Nope.
Lackey, no. Nazarian? Patterson?
No.
Patterson, no. Ridley Thomas? Rodriguez? Santiago? Steinnorth?
No.
Steinnorth, no. Thurman? Waldron?
No.
Waldron, no. Wood?
Aye.
Wood, aye.
The current count is 4-6. The bill will be on call. Thank you, Assemblymember Chow. Next, I see Assemblymember Gatto here. We have item number 3, AB 170.
Thank you, Mr. Chairman, committee members. Assembly Bill 170 has changed substantially in the last few weeks with guidance from this committee. We've addressed the concerns about the opponents. This bill now just has a information form that would go to parents and they would have to sign. They would have to sign the information form. We have removed the opposition from USC, Stanford, the March of Dimes, and one other organization. This is the bill that everybody in the committee asked for last week, and I respectfully ask for your aye vote.
Any witnesses in support? Seeing none, any witnesses in opposition? Please come forward.
Good afternoon, Mr. Chair and members. My name is Tanya Robinson Taylor, and I'm here on behalf of the California Hospital Association. While we appreciate the author's amendments to mitigate some of the negative consequences of this bill, the California Hospital Association remains opposed. However, we do look forward to continuing to work with the author on this measure.
Additional witnesses in opposition?
Bernadette Ariano on behalf of the California Children's Hospital Association. We did have an opposed unless amended position. We want to thank the author for taking the suggestions of the stakeholders who worked with him, and we will be removing our opposition and neutral on the bill. Thank you.
Mr. Chairman, Bob Naylor representing Stanford University. We had expressed our concerns in the original hearing. We have removed our concerns, and we thank the author, his staff, and the committee staff for working with us. Thank you.
Justin Garrett with the March of Dimes. We had submitted an opposed unless amended position. We appreciate the committee amendments and the author accepting those amendments to resolve those concerns. As our letter indicated, we still have some concerns regarding the federal guidance moving forward, and we look forward to continuing to work on that. Thanks.
Angela Gilliard with the University of California. We had concerns in the last hearing, and we've removed our concerns. Thank you.
See no more witnesses in opposition. Any comments or questions from committee members? Okay, we have a motion. We have a second. The motion is due pass as amended to appropriations. Assemblymember Gatto, would you like to close?
No, thank you. I respectfully ask for a vote.
Thank you. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Aye. Mainshine, aye. Bonilla? Bonilla, aye. Burke? Burke, aye. Chavez? Chavez, aye. Chu? Gomez? Gomez, aye. Gonzalez? Hernandez? Lackey? Lackey, aye. Nazarian? Patterson? Ridley Thomas? Rodriguez? Santiago? Steinnorth? Steinnorth, aye. Thurmond? Waldron? Wood? Wood, aye. Needs one more. 9-0.
The count is 9-0. You need one more vote? I will leave the bill on call.
Terrific. Thank you very much.
Thank you, Assemblymember Gatto. Let's call Assemblymember Gordon. And as you're coming up, Assemblymember Gordon is going to do item number 5, a really quick item, AB 339. That'll be followed by Assemblymember Grove. And as he's coming up, we're going to take on for amendments only AB 1357, Assemblymember Bloom, item number 32 for amendments only. This is an amendment and we refer to Committee on Health. We can entertain a motion.
Move the bill.
We have a motion?
Move the bill.
Do we have a second?
Yep.
Okay, we have a motion. We have a second. Any questions or comments from members of the committee? Seeing none, Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Mainshine, aye. Bonilla? Bonilla, aye. Burke? Burke, aye. Chavez? Chavez, aye. Chu? Gomez?
Aye.
Gomez, aye. Gonzalez? Hernandez? Lackey?
No.
Lackey, no. Nazarian? Patterson? Ridley Thomas? Rodriguez? Santiago? Steinnorth?
No.
Steinnorth, no. Thurmond? Waldron? Wood? Wood, aye.
Ma'am, if I could change my vote to yes.
Lackey.
Misunderstood.
Lackey, aye.
Mr. Chairman, this is just for amendments, correct?
Yes, this is not on the substance. We'll have a chance to vote and weigh in on the substance of the bill next week.
I'll vote for aye.
Thank you.
Patterson, aye. Nine, we need one more. Yes.
The count is 9-0. 9-1, excuse me. The bill's on call. Let's turn now to Assemblymember Gordon, AB 339, item number 5.
Thank you, Mr. Chair and members. Some prescription drugs are simply very expensive. AB 339 does not address why this is the case. AB 339 is actually designed to protect consumers. AB 339 builds on existing California law and federal guidance to provide basic consumer protections that take the patient out of the middle of the negotiations between health plans and pharmaceutical manufacturers. Californians with cancer, HIV/AIDS, hepatitis, multiple sclerosis, epilepsy, lupus, and other serious and chronic conditions need high-cost specialty drugs. Today, consumers with these serious health conditions can be asked to pay as much as $6,600 for a month's prescription for a single drug. AB 339 limits what a consumer pays to 1/24th of the annual out-of-pocket cost. You will hear from the opposition about the rising cost of prescription drugs. However, does this justify consumers being forced to spend over $6,000 on a single prescription? I would say no. The Los Angeles Times recently referred to a cap of $200 per month as a sensible cap on costly drugs. Some of the opposition says they are willing to support reasonable cost sharing, and I am more than willing to work with them. For those that insist consumers must bear the burden of rising costs because health plans and pharmacy benefit managers are unable to negotiate effectively with pharmaceutical manufacturers, we say that AB 339 is intended to get the consumer out of the middle of that conflict. Many of the other provisions of AB 339 are taken from existing California law or recent federal guidance. Recent federal guidance, which applies to coverage sold to individuals and small employers, prohibits discrimination through reduction in the generosity of a benefit to a subset of individuals. AB 339 codifies that requirement in California law. You may also hear that somehow AB 339 interferes with Covered California's efforts. Covered California is a state agency bound by state law. And to their credit, they have moved ahead to try to find a solution on high-cost prescription drugs for their 1.4 million enrollees. AB 339 improves on their efforts to provide protections for the 23 million Californians with coverage not provided through Covered California. As California has implemented the Affordable Care Act time and time again, we have done better than what is required by federal law. AB 339 is another bill that implements and improves on existing state law and federal guidance on the Affordable Care Act. I am happy to accept Amendments A, B, and C, which are three of the four amendments suggested in the committee analysis. We will not be accepting Amendment D because we believe it violates the final federal guidance related to not placing all or most drugs on the highest cost tiers. I ask you to join me and my co-author, Speaker Tony Atkins, in supporting these important consumer protections which ensure that Californians are better able to afford their prescription drugs and the drug benefit designs are not discriminatory. I respectfully ask for an aye vote.